name's Heather Goodwin, and I forgot to give Paul the okay. Okay, and I'm an occupational therapist from Manchester, New Hampshire. This is creative interventions for dementia, because drugs don't work for everything. And you know, like the repetitive hollering, or some foods just don't puree well, and you get the spitting and wandering. There's no pill for that. Some aggression or apathy, just not wanting to get out of bed. There's really no pill for that. And plus, with dementia, people are very sensitive to antipsychotic medications. So we'll talk about some behavior management things today. I'll show you some assessments out there to collect outcomes measures. We'll also, just find ways to document it, make goals, make sure you're getting reimbursed for the services that you provide. I think that's really the spirit behind what we should be doing anyway, is try everything first, and then when we can't find a solution, then go to the drugs. But the problem is drugs are faster, right? I could give someone activities all day so they stay awake and sleep at night, but Lunesta is faster. And the problem is he might be snowed all the next day because his cognition's already compromised. Any additional comorbidity, including drug side effects, could decrease his cognizance. So we have to be very careful. All right. I worked in nursing homes for about 12 years, and at the same time I'd worked in home care for 3 years, school systems for 3 years. That was kind of fun. I like schools. It's just the little chairs were killing me. Not a tiny lady, as you can observe. Anyway, I wanted to let you know ahead of time this class is going to be funny because I'm sick. I'm just really sick. It happens when you only work in psych and no one ever lets you work with a hip patient, and you work on the locked unit, and people walk up to you and say A, B, C, D, A, F, G, and you're like H, I, J, K, L, M, N, O, P. And you gotta hold it in all day, right? And then dementia's funny. Yeah. You hold it in all day. You hold it in all day so you can get a rapport with someone, and then she says the darndest things, and you go home and you're like, yeah. She really said that. That's interesting. Like the day I had a client with semantic dementia, and she read my name tag. She was like, occupational. It seems like you're working. And and she read my maiden name. I mean my married name. It was Vasilopoulos. It's Goodwin now. And she goes, oh, Vasilopoulos, like clear as day, like no problem at all. And then she goes, the rapist. Oh. And I never read my name tag like that, ever. And I looked at her, I'm like, you know the difference between the rapist and therapist, right? Space. Yeah. All right, but I am funny, and please feel free to laugh. I try to, use humor for education. And, it is a very difficult disease to work with. And if we can make light of the moments we have together, I think it'll make the content easier. So let's start. I will tell you about my biases and personal interests first. I was a member of the Allen Cognitive Network. I was on their board, their web administrator. In fact, I spoke at their symposium here 3 years ago. I'm not on their board anymore. I've just kind of moved on to other things. It's kind of a small organization. I have my own company called Vital Spark. You can go to my website if you ever want to see, what I do. It's thedementiaspecialist.com. I'll show you my website because there's some cool thing I want to show you. All right, this is my website. All right, so my company's Vital Spark, and the reason why I picked that name is because I think healthcare practitioners need kind of like a defibrillator, blam, to give you that spirit back that we used to have so long ago. Remember when that guy used to say, help me, help me, help me? And you go up to him and say, what is it? And he'd say, I don't know. You're like, okay. And he'd go, help me, help me, help me. And you go up and be like, what is it? It's like, I don't know. But like you wondered, like you still knew he was going to say no, but you still went and asked. Anyway, now we're so busy, we're like, I know you're going to tell me you don't know. I got all this stuff to do, honey. I'm sorry. And he goes, you know me. You know me. And you're like, oh. But, I mean, where is that? I want you to have that again, that feeling. So that's my company, thedementiaspecialist.com. And if you go on my website and click under Activities for Clients, this is a list that we've been generating with our Creative Interventions for Dementia class as part of our mid-stage dementia section. What we do is we're all going to come up with 101 activities to do while visiting your older adult, inspired by the Alzheimer's Association project. And these are some ones I got from Atlanta in 3 different places, Augusta and Athens, Georgia. I'll be adding the Pennsylvania and New Jersey lists next week. I feel bad that I didn't think to do that sooner because I had about 500 activities, but my goal is to get us to about 10,000 by the end of the year, so people don't say, I just don't know what to do with my mom, and put her in front of the TV or take her for a ride, because there's lots of cool ideas, and you could use that as a resource for yourself. And if you want to know other classes that I teach, everything's been recorded, so it is online and available to you, or you can watch for my tours if you like the live seminars like this. This class is being recorded today, so if you do have questions, I'll be giving, either be repeating what you say or be giving you a microphone depending how long you're sharing. Later in the afternoon we'll be doing case studies, and I'll give you a microphone for you to share your information. Other classes that I teach, there's sensory impairments across the lifespan, which is recorded in It's about a 3-hour course. There's my fat face right there. I found that sensory interventions, it doesn't matter how old you are. The interventions work for all ages, so I tried to do some age-neutral interventions. This class, you have my tour schedule, and then Dementia Management Advanced Skills for the Healthcare Practitioner. I do live and a recorded seminar through cross-country education. And I also do private instruction if you want me to come to your company and do training. On breaks, I sell my books and my products, which are also available on the website. The only thing is you would save shipping if you're buying them from me today, and I put some little discounts on the prices. If you ever want to just look at the site, you could compare what they're usually at. That USB I'm selling for $90. Those CDs are still $40. That book's $20. That book's $40 because it comes with a CD here. It doesn't come with a CD on the website. And this book's $30. That book's $20. And I have a sensory stim pack also that I sell. I'll be doing that at breaks if you're interested. I have a USB card reader. You saw the commercial, the little phone reader. I wouldn't have any personal information if you wanted to make a purchase. Also cash or credit card. That's on breaks. If you want to know more about me, I take the occasional travel job at an ALF or a skilled nursing facility throughout the year. I do a couple of 13-week assignments, and then I do my tours and my classes. That's me. I haven't taken an assignment for a little while. Oh, I'm also a stand-up comedian. But I don't let those cross. Keep those separate. Yeah, I'm being interviewed for the Spotlight Follies special as a dementia specialist from one of my comedian friends, so it's kind of interesting interview. All right, so that's me. Your first break will be at 9:30. Lunch is from 11:30 to 12:30 on your own. KOP Malls across the street, so you can have fun getting lost there for about an hour. Then we come back, have another break about 1:30, and conclude at 3:30. Feel free to, I will have a question and answer section at the end of each piece. We're going to talk about family interventions, early, mid, late, and end stage interventions for dementia. And at the end of each section, I have a question and answer segment. But if you have questions while I'm talking, you could feel free to raise your hand, and I'll answer it then as well. All right, let's start with the current demographics and a short definition of dementia. About 4 million Americans have Alzheimer's disease, and that number is growing. We have the baby boomer generation, more and more people getting over the age of 65, and the average worldwide risk of getting Alzheimer's disease is about a 5 to 10% chance by the age of 65. So this is part of normal human development. If you think of a bell curve, anything under 5% would be abnormal. What happens is a myeloid, a regularly occurring protein in the brain, aggregates to the neuron, getting kind of sticky, filmy onto the neuron, and then tau, another regular protein in the brain, becomes tangled, kind of like throwing sugar in a cotton candy machine, which will strangle the neuron and cause neuropathy. And that accounts for about 60% of your permanent dementia cases that you work with. Other irreversibles, like Alzheimer's, that you might work with include Lewy body dementia, where the Lewy body protein aggregates to itself and makes little protein clusters in any region in the brain, and depending where it grows, that would differentiate the diagnosis. You have LBD, which is just a general Lewy body dementia. PDD, which is Parkinson's disease dementia, part of the Lewy body category. About 50% of your Parkinson's patients would develop a Lewy body Parkinson's disease dementia. And those Lewy bodies are growing in the substantia nigra and the caudate. Then there's diffuse or cortical Lewy body dementia, and that's just indicating where they're growing. But they'd all present with Parkinsonian type symptoms. It's hard to know who's who. We just know who's taking the dopamine, which is determined by the doctor for the substantia nigra growths. Then about 10 to 20% of your cases include vascular type dementia, or MID, multi-infarct dementia, which could also be chronic and progressive in nature. We know some people have strokes and they have a complete turnaround. Some people, it can cause some very permanent damage, and it's a pretty much a waiting game for us with the clients, waiting to see if they get nonverbal, if they're getting any of the tone back. But it could be chronic and progressive, and that includes traumatic brain injury, stroke, TIAs, CVAs, etc. So those are probably the most common irreversibles that you would come across. And then there's some rare dementias that you probably see, 1 or 2 times a year, like MS has a related dementia, multiple sclerosis. It's a disease of the central nervous system. It affects the brain, the optic nerve, and the spinal cord. Please know that, because there are also type A personalities and notorious bridge burners in healthcare. But if you know if part of that's a frontal lobe deficit, it'll help us be a little patient during their exacerbations when they're not using their slide board for transfers because they forget they got myoclonus in their legs and stuff. Then you have frontal temporal dementia, including Pick's disease, where tau might make little protein growths of itself throughout the brain. Instead of doing the cotton candy effect, it makes kind of like a meatball effect in only the frontal and temporal regions. And then you have, AIDS has a related dementia. If you work in a group home with a developmental delayed, you'd also see, Down syndrome has an Alzheimer's associated with it. And then we have Creutzfeldt-Jakob disease, which is a prion abnormality. It's like a mad cow variant. And then you have Wernicke-Korsakoff syndrome affecting the Wernicke areas of the brain. It's basically a B deficiency. So there's a lot. There's a lot of them. But then sometimes people have a complex constellation of medical difficulties that could cause a dementia. But that could be a group of reversibles, which we call delirium. Like, let's say you get the eye for the UTI, right? You good for that? You're like, I think they got a UTI. Well, sometimes you have this feeling that whatever their confusion is, it's kind of transient in nature. So when you ask about a UTI, you're asking if they kind of have a delirium. And when the dipstick comes back negative, we're usually like, oh, I could have sworn. There's a bunch of them, actually, that could cause a reversible dementia, including a UTI. That's always the first one you should check for. But the next one you should check for, what are their sugar levels? Because that can throw their cognition off. Are they in pain? You know, that could show their cognition to decline. How are their oxygen levels? Anoxia can cause some confusion, or normal pressure hydrocephalus. Or depression is a very debilitating disease and often looks like dementia. In fact, it's nicknamed transitional dementia. It can take up to 2 years to find the right psych med for that one. And I think it's 42% of patients in long-term care facilities have a diagnosis of dementia and depression, and that depression's not being treated. We also would probably, look at their vitamin levels. Do they have a deficiency of some sort? Metabolic disorders, vascular disorders, nutritional disorders. So it's complex. And we just have to take a holistic look at someone, because maybe Mr. Left foot, right foot walker, left foot, right foot walker, left foot, right foot walker, maybe that's not his baseline. Maybe we could see if he's not taking the Remeron, his cognition will boost and he'll actually be more likely to feed himself, which we might have given the Remeron because we'd hope he'd be more hungry. But if he has more cognizance, he might be able to grab the fork, do it himself. So we have to take a very holistic view. So that's dementia, and there's a lot of it. I'd say at least half of the patients that you work with in long-term care or assisted living have some sort of cognitive disorder, or else why else did they need you? They would have just gone home and taken care of themselves. Just simply having surgery and being on painkillers, being in pain, that could cause confusion, stress. All right, let's talk about costs for caring for clients who have dementia. We'll look at caregiver burden and a couple of catchphrases that are coming around your company that people are saying in such an authoritative tone, but they might not know what it means when they're saying it. So, culture change. There's a culture change going on. I don't know if you had a meeting on it. Did you have a meeting on it? Anyone have a meeting on it? Yeah? Huh? You sure you will? You sure you will? I remember a couple places I worked at, they're just posters saying, we're going to have a meeting to talk about the culture change. And, we're just like, well, there's a culture change. Better be aware of it. And then falls. Falls are natural. It's a natural part of aging. It's another phrase that's probably going to be coming around soon. And then excess disability. Don't do that. That's going to cause excess disability. Now, people are walking around saying these things like dignity issue, HIPAA violation. They never read the HIPAA laws. So we have to go through and explain what they are and have intelligent conversations about them. All right, for about every month, CMS, the Center for Medicare Services, pays out about $1 billion to cover Alzheimer's-related expenses. People who have Alzheimer's disease, CMS pays out a total of about $89 billion to pay for all of their health care costs. So it may be Alzheimer's related, it might be because of a fall they had, or because of a medical status change associated with their disease. For every 5 years, that's about $259 billion, and that's a lot of money. If we could slow down or eradicate the disease process, that would provide tremendous savings, and hopefully we could use that money to help other people, or maybe it'd be more money in your pockets. Burden is a heavy load caring for the client who has dementia. Heavy weight. Every day I have to wake this person up who is confused. I love them. I'm slowly losing somebody. I have to deal with grief, stress, and having to care for them. And maybe I'm part of the sandwich generation between the ages of 35 and 65, taking care of my kids and my parents. So we're squished. That's where encumbrance comes in. It's when the load is so heavy that you could barely bear it. which causes its own health-related issues. Culture change. Medicare made a lot of new mandates last October to try to change the way that we're running long-term care facilities. And it's supposed to guide us into creating these environments for our clients that are more home-like, less of the sterile kind of milieu, trying to give more power and independence to the client. And the way that CMS does it is they create a lot of mandates. And we're going to want to meet them because CMS won't give us any reimbursement if we don't, or we'll be fined. So if we were to completely adopt all these 400 F tags that nursing homes are under, we would be removing the nurses' station. We'd be getting rid of rolling med carts. We'd be making that nursing station area maybe a common area. People can decorate their own rooms, bring in their own furniture, their own pets. It'd be more like a college dormy kind of atmosphere. People could sleep as long as they want. They could sleep in as late as they want. We just provide a continental breakfast. You know, bring them their tray at a regular time because of that mandate. And then if they don't want to eat it, they could have a continental after. Drugs would be kept in a safe in each individual's room. Anyone doing that kind of stuff? Anyone have an eat-in alternative going? Does it work? Oh yeah, and then restraint, redefining the restraint. I mean, CMS is making their new, what's it called, action plan to try to reduce the use of chemical restraints and anti-psych meds. That might be why you're here today. Also, restraint could be a chair alarm. It could be you telling someone no. Your voice. It's lap buddies, chemicals. Anyone try no chair alarms? Anyone try that one yet? Try that? Is that scary? No chair alarm. Is that scary? People have done it. They've done it. You just become more in tune to needs-driving behavior. So, like, what was his need that he went to get up? And instead of meeting our needs, to have him sit down because we're overwhelmed. It takes a while. That's culture change. Falls are a natural part of aging. CMS had done a meta-analysis of all of the long-term care, like skilled nursing facilities, falling star programs, or any programs we'd done to try to reduce the incidence of falls. And these programs did not create a statistically significant result on reducing falls. We were able to reduce injury, but not the incidence of falls. So CMS puts out the statement, falls are a natural part of aging. Why would they say that? Why on earth would they say that? I don't know. They're starting to collect more data of the non-institutionalized age. Home care is having to record now when people fall. Why would they want that data? You guys are smart. Figure it out. They're an insurance company, okay? They want to save money. They don't want to have to pay for every single little referral for a fall. And this is a big thing for them to say maybe they're not going to start reimbursing for a referral based solely on a fall. Is a fall just a fall? Is that all it is? What do you think? It could be balance issues. Why else would people fall? Huh? Decreased vision? Lack of what? Lack of safety awareness. So it's not because it was my 84th birthday necessarily, right? Could be a lot of contributing factors. So if we want to be prepared to make sure we're getting the funding for a referral after someone falls, you're going to have to take a holistic view at your client and say, They fell, but was it because of a physical or cognitive status change? What performance skills have been declining? And we'll just take a very global look to see, well, maybe a fall is indicative of something else. We have to be a couple steps ahead of that one. Excess disability is when we grossly underestimate what a client is capable of, and so we do it for them. Medicare noticed that we're doing that, and they said, well, there's a big difference between how people do in therapy and then how they do in their day-to-day life. Excess disability, we must be underestimating what people are capable of. Therapists have been saying that for years, so we're kind of happy about that one. But the reason why Medicare cares is because it wastes caregiver time and it wastes money. That's why they have their eyes on it. Therapy really cares because if we always encourage capability, then if we have the client perform, that's the cheapest assessment of all. Because if they're always doing things for themselves that they're capable of, when they no longer can, we'll know that they're having a physical or cognitive status change, and thus that could generate a referral. But that's what excess disability is. And it's still, the idea is still in its very primitive stages, but these are some phrases that are kind of coming through where you work, and anytime you hear someone say these words, I think you should say, let's sit down and have a conversation about what they mean, because if we just throw a phrase around, this is the time where we take the power to be prepared and have discussions and make a plan to advance quality of care. But it also means that we get a lot of pushes and pressure on us in different types of industries. And I think whatever your setting is that you work in today, you'll have a hard time putting in creative interventions because you may be used to working in an environment of no, don't, that's illegal, or we haven't done it that way, or we've always done it this way, or we've never done it that way. And so it must be, we always worry if we're going to take a misstep and get into litigious thinking. And what I want to tell you is, always assume it's okay to do these things up front. Don't ask if it's okay. It's better to apologize than ask permission. Because sometimes when we go and we ask our boss if it's okay to do something, that's a yes-no question. That's poor sales, right? So I just say try it and then collect your outcomes measures. Make a good goal. Client will demonstrate willingness to do X in so many approaches, or client will reduce X kind of behavior after so many minutes of Y. And we just use our clinical judgment and say that's what's appropriate. And stick to your guns, back up, because I don't think it's going to be an issue. Those are very big ideas to start a class, and I just want you to feel like you really have the power to make these choices. And it's kind of hard because we're used to working in this kind of environment, and I don't want you to feel that way. I want you to be inspired and excited about some of these cool ideas that we're finding from the literature.